Dr. Ravi Patel, how are you?
I'm doing great.
So good to be here with you. It's a bit surreal. You know, the last time I spent time with you was in your clinic, being tested and going through a bunch of eye tests myself. And you can sharpen some of the terminology that I use to describe eye anatomy and eye health, etc., etc. As we unpackage some of these topics. This talking with you, meeting you, and learning more about the eyes as a whole is something that's close to my heart, as you know, because of the reason that I found you was because of moments of desperation in my own life, trying to figure out what is going on with my eyes, which is something that my eyes has been something that I was always a bit fearful of, because I was always from day one, as far as I remember my life, I think I was aware of how vulnerable my eyes are, and I think that most people walk around not really thinking about the vulnerability of their eyes. Not suggesting that that's a bad thing. It might be a good thing to just live your life without thinking about how vulnerable your eyes are.
Yeah.
But it's something that I was always wary of because of the situation of my eyes. And if you remember the exact numbers of my eyesight, where if I tell people what those numbers are, they either think that I have no idea what I'm talking about. Even I've seen eye doctors who I've sat down in their office and I've kind of given them a background to who I am and my eye situation.
Yeah.
And they don't believe me until they put me, under one of those cool machines that you use.
Yeah. Well, I think it's true. If you think about it, the number one fear that humans have in general, if you think about all of our senses, is losing sight. People would rather die than lose their sight. It's that precious. So while you're right, it's not probably on top of your conscious thoughts where you're like, hey, I walk around thinking about, oh my God, what can happen to my vision? It's one of those things that people have an innate fear of anyway. And I think in your particular case, it's because you grew up differently than everybody else, right? You saw the world differently. You were already acclimated to eye exams and eye doctors from a much younger age than most people that we see in our chairs. So what's your first memory of when you went to the eye doctor?
I don't think I have a first memory, but I've been wearing eyeglasses since the age of like 2 or 3. So from a very young age. So I think I was wearing glasses even before my first memory of an eye doctor. What I do remember is that besides my bad eyesight, I think my overall eye health has always been fairly stable, because every time I did visit a doctor, besides maybe tweaking the prescription of my eyesight, I've never had any reason to worry more than that. I played soccer my entire life, and something that I was always worried about, also with some input from my dad as well, was the whole area around concussions and getting hit in the head, and how that could affect, potentially my eyes, because I've also always been told that I had a higher risk of a retina detachment as well.
That's exactly right.
Which, can you explain what that means? Because I don't exactly know what that means. I just know that it's a bit scary and that I would not want my retina to detach.
So I think the things you said are exactly right. Vision is different than health. So many people have an issue with needing glasses or contact lenses to be able to see well. And as long as we're able to correct your vision, people are pretty happy. We figure out ways to make that work. But then there's organic diseases, something like a retinal detachment, that can cause irreversible vision loss. That means you can't really correct it with glasses or contacts. So when you think about the eye, I know it's such a small structure, but the eye's kind of like a camera. There's 2 lenses, and then there's a retina, or the photographic film.
Is it? Because I've heard read somewhere that it's literally like an extension of the brain.
Exactly. Yep. It's an extension of the prosencephalon, which is a fancy term for saying the front part of the brain. So it's actually nerves that grow into the eye, and that's where all the photoreceptors are. Photoreceptors tell the brain, lights are on, lights are off, this is red, this is green, and your brain then amalgamates a picture of what you're seeing. So when that film gets detached or separated from its connections, it stops seeing. And that's what a retinal detachment is. So it's a separation of the photographic film in the back part of the eye. And you're right, trauma is one of the leading causes of that. When you think about a traumatic event, just like a concussion, if you get hit in the head, your brain bounces around inside of the head and it gives you these concussion symptoms that people are familiar with.
Was it you who showed me? Now I'm remembering the onion.
The onion? I don't think that
the
was
onion.
me.
No, it wasn't you. Or did you tell me the story about the onion inside the jar?
That probably was somebody else,
Okay, so
but it could have easily been me. But the
Yeah.
concept makes sense, where if you have an eyeball which is filled with water and it just bounces back and forth, the coup and counter coup injury can tear the retina and cause it to peel off of the wall of the eye. So it's kind of like an onion bouncing around inside of a jar, is that all the layers will unravel, and that's kind of a problem. But that's probably a more apt discussion for a concussion, I think.
Yeah, and so what happens then when the retina does get detached in the case of trauma?
Yeah. So what you would see is you'd start seeing flashing lights or floaters or a curtain coming over your vision. Those are the signs that tell you and alarm you that, hey, something's wrong. You know, the retina and the inside of the eye, unlike most other places in the body, don't have any pain receptors. So the retina doesn't have a way of telling you, ouch, I'm hurting. So its symptom is flashing lights, floaters. It's going to give you visual symptoms because it doesn't have the ability to sense pain.
And you say so other areas of the eye also don't have pain receptors?
That's exactly right. So the inside portions of the eye don't have really any pain receptors that are associated there. There are stretch receptors. There's receptors in the front part of the eye, the iris, which is the colored part of the eye.
Mm-hmm.
The cornea, on the other hand, as opposed to the retina, is the front part of the eye that you can touch. It's where a contact lens would sit. It has the highest density of nerve fibers in much of the body. And so patients that have had like a scratch on their eye can tell you how wicked that pain is. It's probably among the worst pains that people experience because of how dense the nerve fibers are there.
Yeah, because like now I could put my finger on the white area of my eye without feeling anything.
Right.
But I could not put it on the center part of my eye right there.
Exactly. Because the white part has, over in your case in particular, because you've worn contact lenses for much of your life, you've gotten a little bit acclimated to touching the white part of the eye. So it doesn't feel as much as the dead center or right across the pupil, which is really painful.
It's so fascinating. It really is. And there's so much to make sense of. I really want to ask you first before, because I have a lot of technical things to ask you about the eye. Where did your journey with ophthalmology start from, and why ophthalmology?
Yeah, it's a great question. My journey started very young. I was actually in high school when I was introduced to my mentor, who you know as well, Rob Abel. And
so you've known him since high school days?
I did.
Wow.
Yeah, I did. It's a long story of how we came to know each other, but he kind of took me under his wing. And at a time when I was young, impressionable, and didn't know much about what was what. And I got to see this amazing profession where you take care of a lot of different people, from very young people to very aged people. You take care of people that have amazing vision to no vision. And the gift of restoring sight was so instantaneous, where patients would come in to see him one day and literally the next day, their vision would be back. They'd come with severe pain from like a scratch on their cornea or a contact lens related problem. And within a day or two, they feel amazing. So that instant gratification sort of really resonated with me. And you get to just see, as a young person in their teenage years, how happy people can be going to the doctor. Whereas most of the times when you think about going to the doctor's office as a young person, you think about it as miserable. Like sick people go to the doctors, people that can't walk, people that are having a tough time breathing, people that are having a stroke, right? When was the last time you thought about, I'm a well person that's looking to improve what I can do for my life, and go to the doctor's office? So that then translated fast forward through college and med school and so forth. And it was always something that played in the back of my mind. And it was the comparison point of everything else that I experienced in medical school. Like I'd go through a rotation in emergency medicine. I'd compare it to ophthalmology. I would look at OBGYN, and I'd compare it to ophthalmology. And it always sat there to say, if this is what I'm comparing things to, it's probably what I should do for a living. And now fast forward through medical school and residency and fellowship and practice, and it's truly the best profession that I could have picked for myself or for anybody. It's amazing. I love what I do. And where else would I get to meet people like you and like hear those journeys? I mean,
Yeah.
truly think about it. Do you think the type of journey that you've shared with me would be shared with a gastroenterologist or with an orthopedic surgeon? It's not really where you get to build those relationships with people. So I love that part of my job too.
Yes, and it's also something that, no patient can really hide how much they appreciate because of, even you mentioned at the beginning, that innate fear of losing vision. It's not something we obviously can take for granted. Anyone really. So you do see when you work with patients a lot of the time, like even surgeries, people see a change almost immediately, because I remember even the eye surgery that I underwent, whatever it was, but an hour after I walked into the surgery room, I could open my eyes and see things that in a new way that I've never been able to see before, and it's almost really you in euphoria for a little bit. Yeah,
that's a great term, right? It's euphoric, because you go from having a problem, you go through anxiety because you're worried about what's going to happen, as there's no surgery without risk, no procedure without risk, right? You're thinking, oh my God, I hope I made the right decision. Oh, it's my eyes, it's my vision. And you're so anxious about it that the relief that overcomes you when that vision starts to come back, and it comes back amazingly well for most people, they're just like in awe. And that's the moment you want to capture. Is if you could bottle that joy up and put it into a bottle and open it up every time you needed some help, you would really see what that meant. And we get to experience that vicariously through our patients many times a day.
The reason I was introduced to Dr. Robert Abel was because I picked up his book. I just found it on Amazon. I think The Eye Care Revolution.
That's right.
I think I read the second or third edition, but I read it, and it helped me it helped me relax, but just the way he explained different things, and what many people go through in their own lives, and just the wide spectrum of potentialities and things that can occur in the eyes. So just having that context that my situation is not the worst situation by far, just helped me, and I really appreciated and really liked just the way he explains things from an alternative, holistic point of view, and throwing Chinese medicine into there, and throwing different eye exercises in there, and throwing nutrition in there. So all these aspects that maybe a lot of people, and including me at the time before I read the book, would not think have an effect on eye health, made me realize that they do have an effect on eye health. So when you practice, when you communicate with or communicate with patients, can you tell a lot by someone's eyes? Can you tell potentially like some other things, maybe lifestyle options that maybe should not be there, or just general health, just by examining someone's eyes?
Absolutely. I think Rob's book is very much on point to that. And the beauty of what he does is not only does he tell you the serious part of it, but he can inject humor into his discussions, which I think add a lot of levity. Because you can imagine, like, if you're just sitting there and it's super dry and you have somebody stoically telling you, Danny, this is what's going on with your eyes, this is what we need to do, that tenseness that builds up really doesn't help that relationship. But you're right, in patients with poor nutrition, poor lifestyles, tend to have more ocular disease at younger ages. So for example, let's say somebody didn't have any strong family history, and you see somebody in their 50s that comes to see you with advanced cataracts. That's one of these things we can almost look back and say, hey, why? Why is that the case? They didn't get hurt. This wasn't from a traumatic event. It's not like they were playing basketball, got hit in the eye, and developed a problem. But this was more of their own body developing a cataract. For example, in diabetics, we see cataracts in a particular type at younger ages. Patients that don't undergo cardiovascular exercise tend to have higher than average eye pressures and a higher risk of glaucoma. And so when we see things that we're like, this is something that happens to 80-year-olds and 90-year-olds, and it happened to you at the age of 46, it's just going to put our antennae up that there's a deeper issue, and we'll go looking for it, because you can see signs of high blood pressure and diabetes when we do a full eye examination, which you've gone through umpteen million of them by this point in time.
Yes, and counting.
And counting.
Eye surgery.
Yeah.
Is it as scary as it seems from the patient side? From the patient side, even me, I having different pieces of metal inside my eye while I'm awake with just a couple of numbing drops.
Yeah.
Is very scary.
Yeah.
And just the thought of it, obviously, is very scary. And just because of, again, how vulnerable the eye seems. So is it as scary as it seems from our perspective?
Well, I'll put it from my own perspective, it is, because I had LASIK done when I was younger. And so absolutely, to just sit there underneath of the lights, it kind of helps me empathize with what patients go through, to have been in those shoes myself, of having great vision, right? Like we talked about, needing glasses or contacts isn't a loss of vision. So I had perfect vision with my contacts, and yet I was undergoing surgery to not have to wear them. And just that my heart rate was high, I was getting clammy, all of those things that you experience when you're nervous and anxious, I think every patient goes through. I almost think it would be abnormal not to. Like, I think if you don't have a concern or legitimate fear, trust is different. And I have this conversation with patients all the time. You have to trust in me that my job is to do the best that I can for you. But likewise, I have to trust you that you're going to be the best patient that you can. And if any of that trust is eroded, that relationship doesn't work well. But fear is different. Patients are naturally anxious. They're naturally fearful. Just because they're fearful, it's hard for doctors sometimes to understand that it doesn't mean that the patient doesn't trust you.
Mm-hmm.
They may trust you 100%, but we still have to do our best to kind of alleviate that fear. So I talk to patients as I do procedures. They hear my voice, which sometimes patients think can be a little soothing and relaxing.
Very calming. Yeah.
And having that as the background, rather than the buzzing and hissing of the machines, having the ability to focus on something that's not the metal instruments that are going into the eyes, I think patients kind of respond to that. I mean, you've gone through this, so what do you think? What do you think helped alleviate your anxiety as you were about to go under the knife, and more importantly, while you were doing it?
The thought of, the nerves pre-surgery, what got me through it is the hope of, really seeing a better world after for myself.
Mm-hmm.
And it has been, even with the, difficulties I've faced since, it has my life and relationship with my vision, eyes has been tremendously better than it used to be. So the thought of the after, that paradise that I was aiming towards, really got me into the surgery room, getting past those nerves. During the surgery, I think they I had a drip of something that made me feel good. So I think I was actually very happy for those 30 minutes of surgery. I remember being very happy. Whatever they put inside me made me happy. I remember having a nurse that squeezed my hand and told me that, because I was actually there alone. It's okay. For whatever reason, it was also COVID times and it was tricky days, but I was there alone in the surgery room, and the lovely lady nurse, she squeezed my hand and told me that she's here with me and everything's going to be okay, and she'll see me in 30 minutes. And every few minutes I felt her squeeze my hand.
Isn't that a powerful term though? Like, there's power in touch and there's power in words. And I think words to help patients ease their anxiety, like, my line is, we're going to take good care of you. Patients like hearing that. People in general hear like that, right? We're going to take care of your needs. Doesn't matter whether you're going to a hotel or on an airline or a doctor's office. It kind of brings things down a level. And so we use all those things. And I think people that are better at it, there's definitely people that are better at it than others. I'm sure you can share with some not so great experiences you've had as well. And I'm sure it plays a role, right?
Absolutely. So from the surgery room, I think I was okay. In the surgery room, I was okay once the thing got going, because of the nurse, because of the drugs, and I remember even nice music being played. I had Ed Sheeran being played, which was not what I expected, which is also kind of distracted me in a good way.
Yep.
So it was all very good. From your perspective, as as a surgeon, do you feel like that? Do people, when they get close to the surgery, when maybe that fear kicks in, is that something that you try and put in front of people as well? Is like the post-surgery, what things will most likely look like for you after surgery, how your life will improve after surgery? Is that a vision, no pun intended, that you're trying to get in front of the patient?
Yeah, you absolutely want to try to do that, right? What I've learned is that there's 3 different types of anxiety that people have. Some people have it before the procedure, and they'll call and they'll ask a million questions, all technical questions that sometimes we have to break down into my previous line of saying, you've chosen me for a reason. I think you have to trust the process. Yes, I can go through the technicalities of how the laser works, what wavelength of light is used, what size of instruments we use, but that's not going to help you get through the procedure. Then we have people that freak out, literally rolling into the operating room. That category of people we treat just as you said. You give them some good medicine in the IV or oral sedation. You give them squeezy balls. You play some soothing music, whatever it's going to take to kind of get them through the moment. And then, believe it or not, we have people that freak out after the procedure while they're in the recovery period of that, day or so that it takes to heal, of, oh my God, I can't believe I did this. What did I just do? Did I make the right decision? And I think each of those levels of anxiety is attacked a little bit differently. And you just have to, it's a one-on-one situation. There's no perfect thing to say for people. But my kind of concept is, if you've made it all the way to the day of surgery, much of what you've thought about when you weren't anxious is you wanted to do this. And maybe some of the things you say or some of the ways you act on the day of are all anxiety related, not really a rational, well thought out idea.
When it comes to pain and the eye surgeries, is that something that we've improved on tremendously? Where maybe in the past one would experience a lot more pain, and nowadays, even for me, I did have metal instruments in my eye, but I felt some discomfort after the surgery and some itchiness and some things like that, but no pain.
Right. And that's the beauty of eye surgery. And I think it's historically always been that if you can anesthetize the cornea with topical eye drops or some sort of an anesthetic, the inside of the eye doesn't feel pain.
So is it because of that lack of pain receptors? Not necessarily us putting them to rest.
That's exactly right. And it's much eye surgery that's done in the rest of the world outside of the United States is done without any IV sedation, as you're talking about the drip that you got into the IV. Yeah. It's done just with eye drops. We have enough local anesthetics that we can use to anesthetize the surface of the eye so you don't have any pain during surgery. But Danny, your point's great, that is a big cause of fear and anxiety for patients is this going to hurt? Mm-hmm. And, the description I give, and you can tell me if it applied to you or not, is nothing hurts. You're going to feel pressure and you'll feel water, but nothing should be overtly painful. That's kind of the line I share with patients. Do you think that's a reasonable line?
I think that's reasonable, but surprising. It's still surprising to me that that was it.
Yeah. Nobody believes us either until after they go through it.
Because of how, at least in terms of our relationship with our eyes, touching your eye. So I don't think we're aware that below the cornea, there's no pain receptors.
That's right.
And it just takes, an eye drop or two.
Perfect.
to put that to sleep,
Put
which is
that to
amazing.
sleep.
So you mentioned, there are a couple of examples you gave of different conditions, cataracts and glaucoma.
Sure.
Are those the most, common eye diseases that we face in our society?
Yeah, I think outside of what's called refractive error, like nearsightedness, farsightedness, and astigmatism,
So the refractive error is because we didn't make the differentiation between eyesight and eye health.
Yes.
So the refractive errors, has that got anything to do with the eye health?
In rare cases, it can. So some people that have extremes of refractive error, it can be because of some diseases. But in general, for we'll say 90+% of the population, it doesn't. Being, like my prescription, I was a -2. So that means a little bit nearsighted. I could see things that I would hold in my hands. I could see to arm's length. But beyond that, I would need to wear glasses to see. But when I put glasses on or contacts on, I had no issues with my vision. And that's the truth for the vast majority of people in this country, where they can put their glasses on, put their contact lenses on, and they're able to read, they're able to watch TV, they're able to drive, they're able to live their life. Diseases take away from that. That means despite putting glasses and contact lenses on, you have some kind of limitation to your vision. And in that point, I think the most common ones that we see, especially as we all get older, are cataracts, macular degeneration, and glaucoma. Those are probably the big three of adults, in addition to diabetic retinopathy if you get to a little bit of a younger age population. So it is true that diabetic retinopathy is the leading cause of blindness in working-aged Americans.
And then after that, is it glaucoma and cataract?
In young people, it's trauma is probably going to be up there as well, and inherited diseases. So things that are congenital or genetic, things that you're born with, or things that have been familially passed down to you.
Are there things that we do on a daily basis in general, like generally speaking, that, again, push us towards, any of these conditions?
Yeah.
Like, for example, like smoking cigarettes.
Yeah.
We can, does that have any effect
Absolutely.
on the eyes?
Absolutely.
Because also, even something like that, we think of, okay, don't smoke because of lung cancer.
Yeah.
No one thinks about
their vision,
glaucoma, or their vision.
Yeah. It's a powerful statement to make, right? So the age-related eye disease study, it's called the ARID study. It was sponsored by the National Institutes of Health many years ago. We're now onto the ARIDS 3 study. That's how long it's been going on, of just studying what happens as we age. And we found that there were certain vitamin supplementations that patients could take to reduce the risk of progression of macular degeneration. So if you've been diagnosed with macular degeneration, there's a vitamin combination that can reduce the progression. In that, we also found that smokers were at much higher risk of progression of macular degeneration. So absolutely, smoking is going to deplete us of nutrients and things that our body should be holding on to. It increases free radicals inside of our body. And for that reason, it can cause cancers. It can cause all sorts of different things. And our eyes are not immune from that. So there's not very much good that comes out of cigarette smoking. And I think, and we generally counsel patients, and I think most healthcare providers do, to quit smoking as best as they can.
Yeah.
It's hard for patients, though.
For sure. And I almost gave the smoking as I assumed that it's not helping the eye health.
It's hurting. It's not even just not helping, it hurts.
But is there something maybe less intuitive that we do regularly that is not helping our eyes or even hurting our eyes?
Yeah, I'm not sure that it's less intuitive, right? Like today, the adage goes, sitting is the new smoking, right? We see as many diseases, not only eye diseases, but systemic diseases from people that have sedentary lifestyles and sedentary jobs. That's, again, something that we can do a lifestyle modification, get people moving. And I think industries responded because now there's standing desks. There's ways for people to get up, move around. You have the little treadmills that people put under them. All sorts of things just to keep you moving is good. Movement is medicine. And as a medical doctor and an eye doctor, I don't think that anything isn't interconnected. So your gut health relates to your eye health. If you have bad nutritional absorption, you're likely going to see eye manifestations. If you have bad joints, you're going to have eye problems. Bad skin, you're likely to have vision problems as well, because the skin of the eye, there is a skin layer that the eye is covered with, it's just clear, is subjected to skin conditions like seborrhea and rosacea and acne, all things that we don't really understand completely, but we understand can make an impact in the way that people can see.
So it is considered a layer of skin.
It is transparent. Yeah, absolutely. That's how I describe it to patients, is that it's a modified layer of skin. Our whole body is covered. It's a mucous membrane. So just like the inside of our mouth would be, that's more akin to what covers the surface of the eye. So it's modified mucous membrane. That means it makes water, it makes mucus, and it makes tears in the eye, and it makes saliva in the mouth.
Wow. Is it, generally speaking, is it going to be something symmetrical where both left and right eye will show symptoms of the same condition? Or could something like glaucoma, cataracts attack only one eye?
Yeah, it depends on the cause. So if there's a systemic cause for it, like let's say your diabetes is causing your cataracts, that's likely to be bilateral. Let's say it's just aging that's causing it. It's going to be in both eyes. But if it's trauma that causes it, it'll be in one eye. Glaucoma is usually bilateral, but can be asymmetric. So asymmetry is usually a sign of disease of some sort. Every disease is a little bit different. So I don't think you can say for certain, hey, I only have a problem in my left eye, so this is a problem, let me go to the doctor. But if you see it in both, it's not. What's even more important is that two-eyed problems with vision can sometimes be neurological. So, for example, patients that have a brain tumor are more likely to have vision problems in both eyes at the same time, rather than in the eye itself, like a retinal detachment would be, which happens usually one eye at a time.
Crazy stuff.
Crazy stuff.
Yeah, no, crazy stuff.
Yeah. So there's a lot that has to be upstairs in our minds as we're seeing patients. Yeah. And it's years of training and years of experience that you have to take the story, right? Like you come to see me, I have to listen to your story, take a history, and figure out, what am I worried about? You know, I'm not going to test you for the 5,000 diseases that I know that can happen, but you have to take a careful history, examine you, and then figure out what's most likely to be a problem and kind of help figure out how to manage that.
Do you feel like patients sometimes show up at your doorstep too late, or not too late, but later than they should have?
Absolutely. And I think a big reason for that is fear. I think patients are afraid of going blind. People are afraid of us recommending they give up their driving privileges, which I don't do. But they're afraid of that. They're afraid if their family finds out, their kids find out that they don't see well, they're going to be judged differently. They're going to be treated differently than they otherwise would have been. So I think that's a big part of it. And also, you mentioned it, pain. They're afraid that if they come to see us and we recommend something, it's going to hurt them. So that's what we kind of have to overcome in the initial interactions of new patients.
Where do we stand today? You mentioned the scary word of blindness. You always see these viral YouTube videos of a blind person seeing for the first time with all these new cool technologies that are surfacing.
Yeah.
Where are we when it comes to that, actually reversing blindness?
Yeah. So blindness is defined in two ways. There's reversible blindness, which is a World Health Organization public health related issue. So for example, something like cataracts. Cataracts in the United States is not a leading cause of blindness. And that's because we have good access to care and good treatments to take care of patients. But if you go to the underprivileged and underserved parts of this world, that most certainly is a leading issue. And then you have irreversible causes of blindness, patients that have lost more than we can and correct surgically. And that's where I think there's a great option for innovation. So some of the coolest things that we're starting to see are in inherited causes of blindness. For example, kids that are born blind or born with a disease that leads to blindness. Gene therapies have come a long ways to treat some of the causes And they're very rare, things like Hunter syndrome and Hurler syndrome, things that people have never even heard of, that babies that are born can have some blindness. We're putting chips inside of retinas that are communicating with glasses that patients wear to directly transmit the signal. We're investigating cool types of new lenses that have telescopes built into them to magnify images for patients with macular degeneration. We're evaluating stem cell therapy to see what we can do about damaged photoreceptors or brain cells extensions, as you mentioned earlier. But where the science takes us, only time will tell what's actually going to evolve into true, meaningful improvements in vision.
But how quickly, from your perspective, since you've been practicing and working with patients, have we evolved technologically when it comes to just, in general, not just blindness, but taking care of the eyes?
Yeah.
Is it amazing how fast, to some degree, we're moving?
It's beyond. And I think in the ophthalmology space, probably the only space that moves faster than we do is cancer. It seems like cancer research is at such an exponential pace where every couple of months there's new drugs coming out for treatment of cancer. But in ophthalmology, let's just take what I do. So I'm a cornea specialist by training. So I take care of patients that have cornea diseases, some inherited, some acquired. And one of the more common ones is called Fuchs corneal dystrophy. This is a disease where the inside layer of the cornea is diseased, and as the disease advances, patients get cloudy visions because their corneas become cloudy. At the beginning of my training, this disease was treated with a full-thickness corneal transplant. We would take a cookie cutter, cut out the entire diseased cornea, and replace it with a donor cornea. And the recovery for this, for vision recovery, was about 18 to 24 months in some cases. Towards the end of my training, we had migrated to doing partial thickness corneal transplants, where patients would just be replacing part of their cornea, and the visual recovery took somewhere in the 8 to 12 weeks range. That's a huge difference.
Yeah.
And towards the beginning of my practice, we moved into single layer corneal transplants, where rather than transplanting diseased pieces of cornea, we just replaced the one layer that we knew had the defect in it, and we technically are able to do that. And the recovery is now 3 to 4 weeks for most people. To the next frontier, which is injecting stem cells to replace the cornea diseases. And this is already under clinical trials. And I would think that within the next 3 years, we will be doing this as standard of care for many patients. So just take that into perspective of 15 to 20 years worth of time, going from a disease that took almost 2 years to heal from to injected stem cells.
Which is all amazing stuff. Even as a patient speaking, that also makes me, think of if I'm noticing something in my eye, maybe it's worth waiting a year or two, because maybe that's when the stem cell therapy will be approved, and then I'll have the most advanced and best case scenario treatment versus undergoing what's out there now, and then maybe I'd be a victim of time.
Yeah, and we've talked about this in your own case personally, that the best that I can offer you today is the technology of 2024. I don't have a crystal ball. I don't know what that future holds. And I also don't know what may or may not come to market. Keep in mind that the iterations that got us to the techniques that we do are a lot of failed techniques in the middle. So even in the transition that I described of going from full thickness corneal transplantation to partial, it was fraught with a lot of complications between the two of doctors and scientists that tried things in between that just never panned out. So there is some validity in patients that are really struggling to say, you want the best of today's technology. Yes, if you have symptoms that are really not bothering you, that even your doctor doesn't feel is something that needs surgery, then you're probably better off waiting until you feel that it's necessary. But by no means would I want somebody to say, hey, I have a disease. I'm going to ignore this disease until there's new technology. because that disease will progress. It will continue to get worse. And maybe you let it go for such an amount of time that you unwittingly increase the risk of complications or even disqualify yourself from new technology because your condition's too far gone. So even today, we see patients with Fuchs dystrophy, the condition I mentioned, that have waited a little bit longer than they should. And even with the latest technology and the most modern surgery that we can now do, their outcome may not be as good as it would have been with older technology. So that's the risk in the human body, right? Like, let's move outside of the eyes. Let's talk about knee replacements. Patients that have arthritis in their knees will go for knee replacements when they have pain. If you do it too early, probably not a great idea. But waiting too long is equally bad because your legs have become stiff, your joints, your muscles, your tendons, everything that supports that joint just isn't as healthy as it would have been. So your recovery now isn't going to be as good. And I think the eye is no different, that if you wait for a problem to get so bad that now our surgical risk is higher, your recovery is longer, all of these things have to be considered. So you got to talk to your doctor and see exactly where you are on the spectrum to say, hey, is it reasonable for me to wait to treat this condition? Or do you think I'm better off having treatment now?
If we go back in history,
Yeah.
Before the days of eye surgery,
that's a long time.
So how long are we speaking before the days of eye surgery? How long has your profession been around?
Yeah. So those are two different questions, right? How long has my profession been around versus how long has eye surgery been around? Because even as we know in the Civil War, barbers were surgeons. And if we go back, there's evidence that even the ancient Egyptians and the ancient residents of the Indus River Valley did eye surgeries. The term cataract comes from ancient Greek. It means waterfall. So when people would look into the eyes of patients that had advanced cataracts, it would look like a waterfall coming down, a whitening of the pupil. And there was a technique called couching, even before anesthetics were invented, where a needle was put into the eye and the cataract was just pushed out of the way. And that would restore sight for patients of the ancient era. That has obviously come a long ways, and the evolution of eye surgery dramatically got better with the invention of topical anesthetics. So, as bad as it sounds, cocaine started eye surgery because cocaine is a topical anesthetic, and you can use it as eye drops to numb up the eye. And that is the initial evolutions of where being able to operate on an eye started, of just being able to do it.
So even back then, ancient Egypt times, we're talking about a few thousand years ago, they were performing eye surgeries.
They were. Mind-blowing.
Mind-blowing. Successfully with that technique of were they restoring vision and pushing the cataracts out of the way?
I'd have to believe the answer is yes. Otherwise, you wouldn't have had people doing it.
Yeah. But what was the, so they would stick a needle where in the eye?
They would stick, again, I wasn't practicing at the time of the ancient Egyptians, but the concept is you would probably stick a needle through the white part of the eye, and you would just push back the lens or the cataract that grew in the eye. A cataract is a clouding of the natural lens of the eye. We're all born with a natural lens, and when it gets cloudy, it's called a cataract. There's obviously degrees of that. Cataracts that we operate on today, they never would have operated on at the time of the ancient Egyptians or the ancient Greeks. But when a patient was blind, let's say that they could barely see shadows and light out of their eyes. If you could knock back the obstruction to seeing, people could see better. You could finally be a more productive member of society. It increased personal safety. That's even true today, though. There's many studies that have been done to show that people after cataract surgery are less likely to have hip fractures, just by virtue of getting more light inside of the eye and seeing better. It's a dramatic risk reduction in falls and hip fractures. We're learning more and more about Alzheimer's and neurodegenerative diseases of just being able to see better. Are we able to kind of stave off the development of neurodegeneration with better vision? So a lot of time will tell where all this will go to. But going back to the ancient Egyptians, they pushed the lens out of the way. Light could get inside of the eye, and usually that would restore some vision. This was before there was antisepsis and sterilization techniques. And so how successful they were over what period of time versus what rate of complications they had, I have no idea.
So it's honestly so cool and crazy to think about. But just in the context of, again, we were talking about how scary surgery is today with everything that we do know and all the precautions that we do have and all the experience that we do have.
Yeah. But that's how scary blindness is. That's right. So for somebody to have surgery 2,000, 3,000, 4,000 years ago, the fear of blindness had to exceed the fear of surgery. And that's when people would sign up and have something done. And I'm certain, just as people do today, not through social media, of course, but their own local social media, somebody would go and tell their friend, their neighbor, their parent, their loved one, hey, I was totally blind. I was falling all over the steps. I was bumping into walls. And I went to go see this person who took care of this problem for me. You should go see them since you're bumping into walls. And it was the ancient Greek version of social media.
Yeah. So cool. And, so when did your profession come into play?
Yeah. So the profession of ophthalmology is probably an advent of the late 1800s and able to be doing surgery on eyes because we needed anesthesia to be able to do that. And so before that, I'm certain that procedures were done. However, there really wasn't great anesthetics available to have them be successful. Our profession then really took off with the advent of the operating microscope to be able to magnify the eye, to be able to see the minute structures and to see what we do, which really started to take hold in the United States in the 1960s and 1970s. Of being able to operate with a microscope. So each procedure that's been done has come under great evolution, from rudimentary surgery in the 1800s of treating glaucoma by just putting a hole in the eye, to the most modern, elegant surgeries that you guys can all see on YouTube that we do today, that within an hour or two, patients are seeing better.
If we go back in history to simply eyesight problems and not necessarily health problems in the eyes.
Yeah.
What would one, with someone like with my eyesight, which is roughly minus 18-ish, what would be done with someone like that? Considered blind?
Sadly, the answer is yes. Glasses have been made for a long time. We have photographs during the, even before the Renaissance, during the Middle Ages or the Dark Ages in Europe, where if you look at photos, there are people that had monocles on their eyes or glasses that were held up of some sort. Not the high index lenses like we use today, but people figured out ways to see better. And if it could be done by using some sort of an external lens, it would have been done. If you remember, your glasses were very, very thick.
I remember.
He's like, don't remind me. I remember this really well. That was harder to recreate because the science and elegance that would have to go into making a lens that you would need to maintain the clarity of a glass material, glass had to be blown or manufactured to do this, was not easy to do. But 1400s would have been a time where glass blowing and things were taking off in Europe. And so glasses and lenses started to be manufactured. So that's how it was corrected at that time. That's, again, vision problems that we were able to address.
There's a concept called eye yoga. Have you heard of that?
I've heard some details about it, but I don't know that much about it, I must admit.
But eye exercises in general. I like the coin term eye yoga.
Yeah. Gives a relaxing term to it.
It does, absolutely. But eye exercises, which Dr. Abel also writes about in his book.
Yes.
Is something that, also the world that we come from, the manual therapy, exercise therapy, movement therapy, all these different areas where, if one does dedicate himself to, working on their joints, on their flexibility, they will see improvements over time. can that be applied to the eyes? Because it's something that is, as a concept, is becoming popular in different niches and different pockets of individuals,
Yeah.
and something that some invest time in and report to see positive results.
Absolutely. It's a big arena in sports medicine right now is vision therapy, where young kids, teenagers in particular, that are playing baseball, that are like doing some sort of athleticism, are undergoing these eye exercises or these training modules to be able to teach the eye and therefore the brain how to see the ball a split second faster. So you can read the pitcher. You know if it's a curveball coming towards you or a fastball coming towards you. These are all active treatments that people are undergoing. There is a lot of science behind this concept of vision training, eye exercises, visual rehabilitation. Whether or not it'll apply to the masses or only the elite of athletes is yet to be determined. I can tell you my own story. I have a patient that unfortunately diagnosed with cancer in one of his eyes, and this was his only seeing eye from childhood. He really had very limited vision in the other eye, and it was about 2100. That was his level of vision. In English, that means for what I as a normal person can see from 100 feet away, he would have to be 20 feet away to see that. When he lost one eye to cancer, the other eye, which was his quote-unquote lazy eye from childhood, over a year and a half, we've seen some vision improvements. Now, it's never gotten to 20/20, but he's now 20/50, which means he can see it from 50 feet away. From 20 feet away, what I can see from 50 feet away instead of 100, right? That's a doubling of his visual function. It's pretty remarkable just by using the eye, by forcing it to be used. And that's something that we don't really think of as adults. Children, we know it works all the time. If you have a 4-year-old kid that can see only out of one eye, if you patch the good eye and you force the weak eye to start seeing, you'll restore vision. And that is the current accepted treatment for this condition called amblyopia or lazy eye.
In today's world, where every kid is being has an iPad 3 inches away from their face.
Tell me about it.
And that's today. Even in my childhood, every kid is sitting 2 feet away from the TV, watching TV for hours.
Yeah.
What is that relationship between putting a screen in front of your face and potentially hurting your eyesight?
Yeah, we struggle with this with our own children. Like my kids are young, and it's literally, I could say they were born with iPads at this point. But my mother would say I was born with video games. So I think each generation has their vice, and I think the near vision stimulus is this generation's. Because of it, we are seeing more myopia or nearsightedness. If all your brain knows is a world that is within 20 inches of your eyes, it's going to learn that that's your world, and it's going to change, and it's going to evolve to just being able to see 20 inches away. And that in ophthalmology terms means myopia or nearsightedness. So we are seeing
we're basically we're molding the brain to create myopia by having the iPad close to our face for so long.
That's exactly right. So when we talk to young people, and even people that sit at a computer all day for work now, and their occupations are also 22 inches in front of them, we tell them it's like the 20-20-20 rule. Every 20 minutes, take a 20-second break to look 20 feet away. And you kind of just want to remind your brain.
Every 20 minutes, take a 20-second break to look 20 feet away.
That's right.
Okay.
And if you practice that and you do it regularly, you're almost teaching your brain that there is a world outside of 20 inches. It exists. 20 feet and 20 inches are two totally different numbers. And you just have to reprogram the brain. We're doing a lot of evaluations for treatments of what's called myopia control, or ways to stop eyes from growing and stop eyes from changing and becoming nearsighted in young children. I truly think it's a problem. Eye rubbing and close range vision are among the two biggest problems that face our young people.
Eye rubbing.
Eye rubbing. Eye rubbing.
It's a problem because eye rubbing feels so good.
And it's a great way to damage the eyes. I tell some patients that when I was younger, yes, we had video games, but we sat much further away than 2 feet because the computers weren't there. We did them on our TV screens. And so we were usually towards like the back of the room playing the video games, and the consoles were closer to the TV. And your stimulus was much farther away, 6-10 feet. It wasn't 2 inches away from you. The fact of playing things on a Game Boy, which was one of the first iterations of my childhood that came out, of playing Tetris on a Game Boy, which was right in front of you, it really dramatically started changing the way games are played. Then they're on computers and all sorts of things that are just much closer, and now the iPad. So let's talk a little bit about eye rubbing in relationship to this. When you're staring at anything, you stop blinking. If you look at people that are watching TV or reading, their blink rates start to go down. They don't blink as much, which means their eyes start to dry out, especially if you're under a heater, under lights, under whatever other unfavorable condition. When your eyes dry out, you're going to rub. Rubbing in some sensitive patients can actually damage the cornea. It can cause a change in the shape of the cornea and thin out the cornea to a condition that's called keratoconus. In rare cases, the cornea becomes so misshapen that it looks like a cone, like the pointy end of an ice cream cone. And this condition we're seeing in now 2% of the population is coming in with keratoconus. So these are things that rubbing and near vision are causing challenges with. So getting people to refocus, look far away, blink, all these things can help that, and changing habit of not rubbing your eyes and just using things on the TV. So now when my kids want to play on their iPads and they're on their Nintendo Switches, we'll actually have them plug it into the TV so they can sit on the sofa with their controllers and play their video games.
So even an adaptation like that makes a difference with someone's kids.
Yeah, absolutely.
Just not being always 2 feet away. And like, us, we're always on our iPhone, smartphone. Yep. So it's the same concept, right?
Very same. Take a break, look far away, look through a window, look at a tree. They're beautiful. Mother Nature is beautiful. Stop and smell it.
So even if you just stop for 20 seconds, look out into the distance, into the trees, that can help.
Yeah.
Because you're simply reminding your brain that there's more out there than the Game Boy or iPhone.
It does. And if you really start and do it, what you'll notice at the beginning is that it's really hard. It's not the stopping that's hard. It's seeing the tree that's hard. Because your brain is so hyper-focused on looking at things that are close that you'll start looking at the tree and say, oh man, that's blurry. I had no idea that tree was that blurry. And then you'll wait that full 20 seconds and it'll start to come into focus. As you become more habitual at doing that, it should take you less time to get the tree into focus. You want your brain to know there's 2 worlds. There's something far away and up close, and you're just retraining your brain to do that. And you can train it.
And is it the electronic part that's the problem, or that it's close to our faces? So is it the same problem if I have a book in front of my face most of the time? Or a newspaper?
Newspapers are a different story because the print is very faint in most newspapers. But I think a book versus an iPad, the stimulus that comes from the light from the iPad affects other things. We know that blue light can affect our circadian rhythms and our sleep-wake cycles. We know that artificial light of different sources just isn't ideal. And so I'm not sure, I don't think the science is defined yet on that, of how much worse an iPad is versus a textbook, but any near work this applies to. So even, yes, the bookworm should take a break and take some sort of a break to look far away. But I don't know of many people that spend as many hours on a book as they do on a screen. It's a cool test, even if you do it now. Like, take out your phone. You can do it. Have you done this before to check how much screen time you use?
Oh, right. Yes.
So you've done that,
yes,
right?
I know.
For your guests, like what you do is on your phone, any phone works, you press the settings button, and then you press the screen time button, and you get a report that tells you what your weekly screen time usage is, on how long you have been on your phone looking at the screen, and it tells you in terms of the number of hours. So looking at my phone, and I'll share, over the last 24 hours, my screen has been on for 3 hours, and it's been, and that's my on time for the screen. So I've had 3 hours of screen time usage in the past 24 hours. do keep in mind, 8 hours of that I was sleeping, so my screen time was off. So rate that for the balance of the 16. That's my own personal number. And
I'll share mine too. I just see so today my screen was on for 42 minutes so far.
Yeah.
And I just get my daily average from last week is 3 hours and 50 minutes.
That's really good. I mean, for somebody young as you are, that's amazing.
Yeah, but I've been, it used to be worse. I'm doing my best to not scroll on Instagram, and thank God I am not a TikToker. But that sucks people into way more screen time than they can ever imagine. Just because of, have you ever found yourself scrolling on TikTok or Instagram Reels?
So I'm not on social media, so I don't, but I'm sure that is a large cause of where people have struggles.
But are you familiar with just what it looks like?
Of course.
How easy it is to suck one into that fake reality of amazing 45-second videos that would just lure you in one after the other in all the topics that you are mostly interested in and the types of videos you are most interested in seeing.
Yeah. It's amazing, right? Because they're short
unlimited amount of them too.
There's no content limit, and 45 seconds, 1 minute, it's just enough time to keep your attention before you lose it, and now you're on to the next one, and then you're on to the next one. And the beauty of those, as my wife does them, is you're able to scroll through them, and you can go back and forth to people's stories and their reels if you want to look at them, and you can restart them. These sort of dance things that, these challenges that people do that all take off. It's amazing. So you're right, there's an endless source of entertainment on these devices that it's remarkable what you're able to do.
So to sum that bit up, then at the minimum, if one has to be on their phone there's many reasons to be plugged into a screen in this day and age, right? From as simple as it's your job and how you put food on the table. But at the minimum, you want to balance it out with looking at some trees, looking at some far in the distance buildings, just looking out into the distance. I remember hearing once on a podcast where with kids, just as long as they're playing outside every day, then automatically they will be looking in the distance.
Exactly. It's a good concept of recess for kids that are younger in school, and just getting them out of the house for a little bit of time, regardless of the weather, to be able to reset.
Two more things I want to ask you about before we finish. One is just contact lenses. I remember when I first got started with contact lenses was for the simple purpose of being able to play my sport, soccer, which I couldn't really play with my thick glasses. And I remember my optometrist at the time telling me, just make sure you don't wear them for more than 6 to 8 hours a day. I kind of disregarded that that piece of advice and kind of wore them from the second I woke up until I went to bed, which I'm not proud of, but just it is what it is. And I think it's something that a lot of people do, especially people that I was exposed to. I've even was exposed to a lot of people that were way worse than me in that sense, and just would keep their contacts in, sleep in them, just live with them all the time.
Oh my God, it's the worst.
I know. So can we quickly just in terms of what we know on contact lenses, what is the advice, and how should one approach their relationship with contact lenses for as magical and helpful as they are?
Yeah, it's the best dangerous invention that we've seen since the 1970s. So soft contact lenses came onto the US market in the 1970s. They're not that old. So when you think about it, there was generations and millennia of people that had to see before contacts were even invented. That being said, I agree with you. Athletic activities, a lot of things that people do, you just see better with contact lenses than you do with glasses. You don't have the risk of them fogging up. You don't have the risk of dropping them off of your face or losing them in the ocean. So many things that glasses are uncomfortable about, contact lenses help to resolve. And contact lenses cared for properly tend to do okay. They're most certainly higher risk of infections, which is what we worry about the most. But cumulatively over time, contact lens wear creates a state where you don't get enough oxygen to the surface of the eye or the cornea. And in cases, it can cause irreversible scarring or damage to the cornea just from not getting enough oxygen. So people that have abused, and I will say that term, abused, their contact lenses for decades are at much higher risk of vision loss later in life. And it's hard for a teenager to understand that, right? If you have a 13-year-old that's starting to wear contacts for the first time, they're so excited because they don't want to wear glasses to school. They're happy to be doing this, and that's great, but you have to take care of them. And for me, that means taking them out every single night. Any night of sleeping in contacts is too many nights to sleep in contacts. Give your eyes a break. If your eyes are red or irritated, don't put them in. Wear glasses that day. If your eyes are fatigued and tired, don't put them in. These are all signs that your eyes are telling you it doesn't want more contacts again. You just need a little bit of a break to get you through to the next level. Contact lenses, the manufacturer instructions are really critical. There are daily lenses that are designed for 1-day use, and then you pitch it. There's 1-month lenses, and that doesn't mean that you get 30 wears out of the lens. It means you get a month out of it. When that month is done, you got to pitch it. Even if you only wore it 2 times that month, you can't use it for 30 days. That's something that I think people have a hard time understanding, that concept as well. So read the labels carefully on the products that you're using and just use them safely so you can use them for many years to come. And that's kind of also my own plug for LASIK, is that if you know yourself and you know that you're not a good contact lens person and you'd rather not wear them, go and see if you're a candidate for LASIK or ICLs or some other way to not have to wear contacts altogether.
My last question to you is, which one that we throw at every guest as of the last 20 or so episodes. What is something, it doesn't have to be in your professional journey, but something in your life, it can be from the professional journey, that you've, reversed your opinion on, that you can remember yourself thinking X and now you think Y?
Yeah. I'll answer that on 2 fronts. On the personal front, the one thing I have reversed journey on is how much time I take off from work. There was a time that I would feel very guilty about taking any time away from work. And I would do my best to minimize the days off that I had. I would plan vacations over weekends and take flights on Friday night and Monday morning and come to work on Monday, because there was a guilt element of having patients wait, of not having appointments available. And what I've learned and what I've reversed trend on is, I think your own mental health is equally important. You have to take care of yourself to keep doing what you do to take care of others. And a big source of that for me is spending time with my kids and family. So now when my kids have time off, I tend to take more time off. We have activities that I plan with them to do together. Small things, go take them to the beach, take them to the zoo. And those are things that I didn't do as much of, and now I do a lot more of. On my own professional side, it's contact lenses. When I started in my career, and me, myself, and I were a contact lens wearer, and I thought, they're great. I have no problems with them. This is an amazing thing. They're great. And I thought everybody should do contacts. And over time and overseeing vision-threatening infections, seeing patients lose their vision to infections from contact lenses, I most certainly have reversed thought on inappropriate contact lens wear. And I'm much more careful at counseling patients that they need to do it right and that really consider alternatives to contacts. And I think that's been the big shift in my own practice over the past 15 years, of something that I really wasn't as familiar with all the long-term consequences of, to what we've seen with time.
Dr. Ravi Patel, thank you so much for being here. And I hope that we get to do this again. You are part of my journey now when it comes to my eyes, the anxiety, the fear, the hope, the positivity around it, but the journey. So I'm sure we'll have plenty more topics to talk about next time.
Thanks for having me.